Hi, and welcome to the show. Subscribe at kevinmd.com/podcast. Today, we welcome Edward Anselm, internal medicine physician. Today's Kevin MD article is The Economic Case for Investing in Tobacco Cessation. Edward, welcome to the show.
Thank you. Glad to be here.
All right. So before talking about the article, just briefly share your story and then maybe talk about why you decided to write this article on Kevin MD.
Well, thank you. When I was in primary care, I became very interested in tobacco treatment. That was in the 1980s when virtually no one was doing anything about tobacco whatsoever. And I continued my interest in tobacco treatment, even though my career has evolved significantly. Over the decades, I've become increasingly involved in managed care and value-based contracting. And now at the end of my career, I'm able to bring, my basic interest in tobacco treatment and my skills and insight in value-based medicine together.
You mentioned when you were in primary care decades ago, there was little interest in tobacco cessation. What's the context like today? How much are we spending on tobacco cessation, and are we paying the requisite attention to it today?
Well, it's deeply disturbing to me that to this day, we don't do a good job in tobacco treatment. I like to go to the HEDIS measures on NCQA and look at the incredible progress that we've been made in many, many dimensions of primary care. But tobacco treatment has not been one of them. Our best information about what happens when patients meet their doctors to talk about tobacco shows, and that's the National Health Interview Survey. It shows that only 1 out of 3 patients who are trying to quit smoking get effective evidence-based treatment from their doctors. Evidence-based treatment consists of medications and counseling together. Overall, only about 6% of people trying to quit smoking receive optimal care. This may be why the relapse rate is so high. We have effective treatments, but we're not using it and we're not getting it to our patients. This really motivated my article because I said, how can we change that paradigm? Right? How can we align interests in tobacco treatment? So I endeavored to show the flow of revenue that occurs in either fee-for-service or value-based arrangements that when tobacco treatment is consistently delivered.
All right, so let's talk about that article for those that didn't get a chance to read it. Why don't you summarize it?
Well, basically, I put together all the moving parts that allow a doctor to evaluate their practice and determine whether or not they could add to their revenue and, of course, improve their outcomes if they treat patients with tobacco use more effectively. The first issue is about billing for the 99406 and 407 codes. I've published several papers that show that performance in billing these codes is very, very low. So we do know that doctors provide counseling to their patients, but in many instances, they're not bothering to bill for these services. Medicare and other payers will pay $15, that's the national fee schedule average, up to 8 times a year for any patients. And it's disturbing to know that doctors are performing some work in providing patients tobacco treatment, but they're not billing it. The clinical evidence shows that tobacco treatment can be offered to every patient at every visit, regardless of their readiness to change. So in the fee-for-service model, doctors are missing out on huge volumes of revenue. And again, in the article, I show how they can do the math on that using their electronic medical record system.
So I'm a primary care physician, and I have to admit, I'm actually not that familiar with those codes. So the 99406 and 407, those are specific tobacco cessation counseling codes?
That's correct. That's correct. And what's really interesting is that those are incident to codes. Therefore, you do not have to be face to face with the patient in order that that your office bill for those services. Anyone in a white coat, and it does not have to be a health professional, anyone in a white coat can document a transaction, a conversation where you refer the patient to a quit line, you prescribe medications according to a protocol, and so on. So the doctor is the captain of the ship. He or she says, I want you to talk to my office assistant, medical associate about tobacco use, and then they carry the ball going forward. So it's a few seconds on the part of the doctor, but the office is engineered to provide treatment every visit. And of course, it has a built-in follow-up mechanism where the patient is seen again and the subject is raised again. So you can track your effectiveness.
And what's the reason why most physicians aren't using this code? Is it simply because they're not aware of it, or they just don't want to do it? What are some of, from your experience, what are some of the
Well,
reasons why it's underused?
this is a great question because it has been the subject of research when the Preventive Services Task Force started coming out with their guidelines on tobacco treatment. Why aren't doctors doing it? First thing is the reimbursement rate, $15, seems really low unless you calculate the fact that you can do it 8 times a year and that someone else can be providing the service. The other thing is doctors don't generally feel that they're good at tobacco treatment. In basic counseling, when I was a primary care physician, I measured my own performance. My quit rate for all comers was 5% on an intention to treat basis. Well, that's not very satisfying, is it? Okay, that was before medications were available, and medications doubled my success rate, and that's 10%. Again, if you're doing something at a 10% success rate, you're not likely to get in the habit of doing it. You see, it's below your threshold of perception. This is where electronic medical records can really help you understand how well you're performing and how you can do even better.
All right. What other economic incentives are there to promote tobacco cessation?
Well, the big win is in value-based care.
Okay.
And this is totally transformative because in a value-based arrangement, and that's currently about 40% of medical practices in value-based, and an increasing fraction of that is aligned. Any avoided your payment is based on your patient's past medical utilization, which includes their hospitalizations, their emergency room, their medication use, and so on. So if you are and your practice are able to engender activities that result in avoided hospitalization, avoided medical expense, then sure enough, you will make money because your capitation will be high and your utilization will be relatively low. And that's how you make money in value-based care, by exceeding the expectations of the patient's future morbidity. And so people have done this and have published studies, and I cite the papers in my article, and it comes out to $35 per member per month. It's a lot of money. All right. Think about that in terms of the practice. And if you have a large group practice, the larger your group practice, the larger that number becomes because the fraction of your population that's smoking is, substantially larger. It gets to be a huge amount of money. So it's not trivial. So a couple of missing elements are that most doctors don't even know which patients smoke. Okay. They don't ask them. All right. And that's something that really needs to be changed. And every paper that I've done, I've shown that health systems, and we're talking about major academic medical centers, consistently underreport the prevalence of tobacco use relative to the general population in that county or in that state, significantly. So therefore, they're missing opportunities to help their patients quit smoking. And now that we know that there's an economic vehicle behind it, they're missing opportunities to generate revenue for their practice. Now, changing the practice to optimally provide tobacco treatment is not just a simple transformation. It requires what I call a systems change. And there's a literature on that. And in my article, not only do I point to the literature on systems change, I talk to very well-designed models that can determine whether or not there's a cost benefit for you. So my message to doctors is, please do the math. Okay. I mean, we're trying to provide great service to our patients and in a business environment. And if there's a product line that comes along that improved quality and generates revenue, it's incumbent on us to look at it. That's why I wrote the article, to put together all the moving parts to allow a doctor to do the math on their practice and determine whether they should implement a systems change approach and exactly what type of systems change they should implement.
In one of the models that you cite in the article, there was an 8 hospital system that had a potential $2 million increase in annual revenue from instituting cessation services. So if we make some of these system changes that you're talking about, the increase in revenue can be in the millions, right?
That's correct. It obviously depends, this is a multi-hospital system, but they have to make their choices. And that involved every touch of the patient. In other words, the hospital would have to re-engineer their workflow so that every time a patient was met by a medical assistant, they were asked about their tobacco status and provided a documented script, regardless of their readiness to change. If they do that, well, there's a couple of $1 million down the road each year. And as they shift towards value-based care, that was a fee-for-service model. And as they shift to a value-based care, well, they're better positioned, right? Because the population that they inherit for their value-based care is tobacco free. So they've actually insured their future savings. I invite people to do the math. It's exciting to imagine that you could make these small changes that will really result in improved patient outcomes and revenue.
So, given this economic context that we talked about today, why aren't more hospitals and medical insurers doing what you say? Why are we still underdiagnosing and undertreating tobacco use? What are some of the barriers that prevent us from doing these systems changes that would benefit economically health insurers and medical systems?
Well, I have to say that there's a form of bias involved in treating tobacco, as it is many addictions, as it is with the treatment until recently, treatment of obesity. Doctors don't feel comfortable doing this and may avoid addressing it. When you see a patient who has among their dozen problems smoking, well, there you have 11 things to take care of before you get to smoking, and smoking is difficult. That's why we need a systems-based solution. So we need to overcome the cognitive biases that people have, the inertia that people have about tobacco. With respect to insurers, there's a somewhat different paradigm operating, and this involves time to return on investment. A doctor creates relationship with their patients over many years. And so in a value-based setting, they have the opportunity to see the benefits of all their interventions over time. Insurers, on the other hand, tend to look at things a little bit differently. And they think about member turnover and their average member turnover. So they're not willing to invest the cost of tobacco treatment, which is overwhelmingly medications, because, well, they say that value is going to go to some other health plan.
Mhm.
This is deeply flawed. I have shared with them my opinions on my website and in correspondence because they have the math wrong. Okay. Tobacco treatment is one of the most cost-effective interventions we have beyond vaccination. And the cost of tobacco treatment nowadays on the cost of varenicline, which had been the number one drug, which was $300 a month, is now below $30 a month. It's now gone generic. It's $30 a month. And it doesn't cost the insurer anything to do it. All right. What they need to do is overcome their own barriers in thinking about this. They don't want to promote health. I mean, it's been anecdotally stated that if it wasn't mandated by the Preventive Services Task Force, the preventive services wouldn't be executed. All right. They wouldn't be included in insurance plans because insurance plans are really to cover medical expense and not preventive services. So insurance companies still have a long way to go in terms of understanding how they can do better in terms of ensuring the health of their populations. It's unfortunate because in reality, they're the largest public health departments we have in the country, encompassing millions of people, yet they don't have public health officers and they don't aggressively promote tobacco
Hmm.
treatment or vaccination or other things. So they have a ways to go. So we all have an educational curve that we need to go through, but the only way that can be overcome is by doing the math. And I invite anyone at any level, individual practice, group practice, health insurer, to read the paper, do the math for themselves. And I think they'll come up with a positive response.
We're talking to Edward Anselm, internal medicine physician. Today's Kevin MD article is The Economic Case for Investing in Tobacco Cessation. Edward, let's end with take-home messages they want to leave with the Kevin MD audience.
Yes, as I like to reiterate, please do the math. All right. Once you do the math, you'll find that you can delight your patients and delight your office managers with improved revenue. And let's agree that it's satisfying. It's satisfying to take knowledge and put it into practice to see better clinical outcomes and better economic outcomes. So the takeaway message is read the article, do the math.
Edward, thank you so much for sharing your perspective and insight. Thanks again for coming on the show.
Thank you so much.